All right, let's get started. So thank you for coming to this breakout session about myelofibrosis. Um, I unfortunately was a little delayed getting in this morning due to various flight issues, and so I missed all the talks, pretty much all the previous talks. So if I'm repeating something, please tell me to stop, or if I'm flying too low, flying too high, no airline pun intended, just let me know and I can adjust as we go along. It's a pretty small group and can take feedback or questions as we go along. And I think we have like about 30-ish minutes for these slides and then a Q&A session afterwards. So when I was asked to do this, I kind of said, well, where do we start? Should probably start at the beginning. So I'm not going to start with the Big Bang, but maybe a little bit more recent than that. But at least with a kind of a brief history of myelofibrosis, of MPNs and myelofibrosis. This is very, very brief, woefully incomplete, but it just kind of shows you like we've been working on this disease for a while. It was first described in 1879, from best I could tell. And it took a while till we saw these kind of leap forwards, right? So there's the 1951 editorial that Demishek wrote. People often cite that as a very insightful moment, at least within MPNs. And then it took another 60 years after that to get the approval of the first medication for myelofibrosis. So a lot of time spanned until we got there. And then afterwards, it's been this kind of explosion, right? So when I make this figure, it kind of really, it's like a funnel outwards. And that's good. We want that funnel to keep going outwards. Lots of advancements as knowledge gain leads to new therapies, but kind of an interesting way to view the history of MPNs and myelofibrosis in particular. And that thing that Dr. Demishek postulated, the thing we've come to talk about a lot now is this JAK-STAT activating mutations. So I did want to take a quick second to review that very, very quickly, because it is so central to how we treat myelofibrosis in the year 2025. And I'm assuming others had talked about it earlier today, but it's all about this pathway being on all the time. So the JAK2 mutation, the MPL mutations, the calreticulin mutations, they all do the same thing at the end. They turn this pathway on when it's supposed to be kind of on, off. It's just on all the time. And that's where we get the proliferation in the bone marrow. And so the analogy I often use, it's when we look at one growth factor in particular, erythropoietin. So erythropoietin is made by the kidney. It goes to the bone marrow. It stimulates the growth of red blood cells. When you have enough red cells or too many red cells, the erythropoietin then gets turned off. It's kind of like the furnace in your house. Getting familiar with my furnace again this time of year. And like a thermostat, right? So if your kidney's the thermostat, it's sensing the oxygen carrying capacity of your blood. It then sends a signal to the furnace turns on, creates a lot of heat. When the heat comes up in the house, this thermostat turns off. So this kind of feedback loop, if you will. And that's really what's going on here, right? And inside the bone marrow, there is the JAK-STAT pathway that is just turned on all the time. It's kind of like the electrical circuits in your furnace. So if you think about your thermostat says, yeah, it's 90 degrees in your house. You don't need to make more heat, but the circuits inside the furnace are still on. And your furnace is still producing heat. And that's why we see, again, erythrocytosis in polycythemia vera and thrombocytosis in ET, and then just the general proliferation with MF. So it's really that system that's broken in this disease. And by identifying that, we've been able to kind of go after it with our therapeutics. Of course, that's not the whole story. There are lots of other mutations that are present in this disease. We've talked about a lot today. And I kind of use a car analogy. So when I first got a car, I had a car with a 4-cylinder engine. It wasn't very fast. It didn't go very far. In fact, I think it took like a solid mile to get up to 60 miles an hour. It was very slow. 1985 Dodge Daytona. Not a very fast car. Sporty, but not very, very fast. And it's kind of like these myeloid disorders. If they have one mutation in them, or maybe two mutations, and in the right combination of mutations, it doesn't go very fast. It doesn't go very far. But if you put a big V8 with turbochargers inside of that Dodge Daytona, it's going to move down the road, right? And same thing with these diseases. If they acquire additional mutations, or they start off even with the more aggressive mutations, the disease can progress quickly. And I think that's a really important point to make. And out of that have born many prognostic models where we use clinical factors to kind of come up with a prediction of how fast that car is going to go. Does this disease have a 4-cylinder in it, or does it have the big V8? And we use these models in all kinds of different ways. But to me, at the end of the day, to help apply particularly transplant. And as it stands today, we think about treating myelofibrosis from a lot of different needs, right? We think about, does the patient have symptoms? Do they have a big spleen? Are they anemic? Or do they have that kind of high velocity disease? And when that patient does have a high velocity disease, we think about transplantation. I don't know if anyone's talked at length about transplantation today, but I want to add a little bit about that in there, because myelofibrosis is a very common indication for transplant. In the CIBMTR database, they kind of lump MDS and MPN together. Almost all those MPN patients are in fact myelofibrosis. So CIBMTR, the Center for International Bone Marrow Transplant Research, it's our nation's database for bone marrow transplant. It's a federally compelled organization that is collecting all the data and all the transplants done here in the United States. And you can see the most common indication for an allo transplant is AML. The second most common indication is either MDS or MPN. And if we actually look at the outcomes, I know Dr. Hoffman mentioned earlier, if a patient's on ruxolitinib and the ruxolitinib is no longer benefiting them, the median survival for those individuals is quite short. And we see that with transplant, though, the survival is pretty good. So here we have with a match-related donor, and these are patients transplanted here in the US between 2017 and 2022. With a match-related donor, the 3-year survival is 67.4%. I mean, compared to a median survival of 14 months, that's a good survival. Now, again, this is not a direct comparison. We're kind of talking in connected network analyses here, but for all patients in the United States who got transplanted between 2017 and 2022 with a match-related donor, the 3-year survival was 67.4%. And we do see a plateau with that curve. It's flat. It's not continuously dropping towards zero. With match unrelated donor, it was 59.3%. With a half match transplant, the 3-year survival was 58.7%. And then even with a mismatched unrelated donor, the 3-year survival was 54.5%. And it's not that we're doing anything new or exciting with the transplant itself. The graft is still the same grafts we've been using since Don Thomas's time. But it's really the supportive care, better conditioning regimens, better antifungals, better antivirals, better graft versus host disease treatments. So really raising those curves. And whenever we think about transplant in the context of myelofibrosis, where the curves kind of intersect, right? So this is an older analysis led by Christina Gowan, where transplant was compared versus non-transplant therapies. You can see here, the lines cross. There is some early complications that can happen with transplant, but that curve then plateaus over time. And if the disease risk is high, transplant can better the long-term outcomes of patients. And that's really what the things that we weigh when we're discussing transplant with an individual patient who's sitting in front of us. Of course, this is not the only kind of clinical needs we think about for a patient with myelofibrosis. We also think about anemia. It's a very common thing. Anemia is present in a large chunk of patients at the time of diagnosis. And over time, virtually every patient will develop anemia, given kind of the course of disease. And we talk a lot about anemia because it's difficult to treat. Not everybody's anemia is the same. There are different reasons a patient might be anemic. It might be due largely to their treatment, due to kind of all the mutations in the bone marrow, due to inflammation. And so all these different therapies we have for anemia address different parts of why this patient's anemic. And so for some patients, it's a matter of figuring out, well, what is going to be the best tool to treat that individual's anemia. So we kind of come up with these algorithms to think about these things. Does the patient also have splenomegaly or symptoms that need to be addressed in addition to the anemia? And we can either add on agents to their JAK inhibitor to try to correct the anemia associated with treatment. Or if a patient doesn't have a lot of symptoms, we can use those agents as a standalone. Or if spleen and symptoms do need to be addressed in addition to the anemia, we can think about the JAK inhibitors that can improve anemia. I know those were discussed earlier this morning. Other things we think about when caring for patients with myelofibrosis, of course, are the symptomatic splenomegaly and the constitutional symptoms, the night sweats, the fevers, the MPN-10 we talk about a lot. I know Ruben gave a talk describing the symptoms associated with MPNs. And really the mainstay here are JAK inhibitors. And the JAK inhibitors were presented earlier. And the question always comes up, well, we have ruxolitinib, and now we have all these others. If three's company is for really a crowd, do we need 4 JAK inhibitors? I think that's a really good question, especially since there's all these other JAK inhibitors that are being developed after this. Do we need 5 JAK inhibitors, 6 JAK inhibitors? And you could be kind of shrewd and say, no, 1 or 2 is probably enough. But I think you could also be more open-minded and say, well, how are they the same and how are they different? And maybe they each have their own role to play. So looking at the currently available JAK inhibitors, they all inhibit wild type JAK2. That's kind of like the place where they all line up on a figure like this. But it's really all the other stuff that they do. Do they hit JAK1 or not? Do they hit FLT3, ACVR1? Do they have effect on proliferation? Do they have an effect on NF-kappa-1 signaling or hepcidin production? And we can think about, well, how can we parse these out? So if we have a JAK inhibitor that hits JAK1, JAK2, doesn't hit a lot of other things like ruxolitinib, it's going to be really good in patients who have pretty preserved blood counts, who have big spleens, very proliferative disease to reverse those symptoms and that splenomegaly that's associated with that individual's disease. But perhaps a patient has a lot of anemia and or a predilection to anemia, and we want to address that as well. And maybe something that inhibits ACVR1 might be better. And then drugs like pacritinib were developed largely in patients who had low platelet counts and more myelodysplastic type myelofibrosis, if you will. And if that's the case, then you might want to think about that agent. And it really muddies the water though, right? So they all inhibit JAK2. Which ones do we use? Yeah, there's some vague sense of where we might want to use these things. But if you turn to the US FDA labels, I think the major challenge is that there's a ton of overlap, right? So we often look at the labels that the FDA puts on these drugs to understand what population we should use these drugs in, but it's all overlap. All if you put it all on a figure like this between blood counts and hemoglobin level and platelet levels here, it's a big overlap. So if you look at a figure like this, I mean, you should use every JAK inhibitor for every patient, but that's not really what we do in everyday practice. And I think we can start to do some practical things in understanding that, yeah, in very proliferative patients, we want to think about ruxolitinib. In anemic patients, we think about momelotinib. And in thrombocytopenic patients or bicytopenic patients, maybe pacritinib. And then we can start to parse these things out for a given individual, which drug we might want to use. Of course, we're handcuffed by a lack of data. These drugs weren't compared against each other, right? We all want that, right? We want to know in a certain population of patients, is drug A better than drug B? But that data just doesn't exist in large prospective trials. There's been retrospective studies, network analyses that have been done, but that's not the good prospective data we want. Really, the only Simplify one is the only phase 3 trial comparing one JAK inhibitor versus another in a large manner. And so it's difficult to parse these things out. So people who do guidelines rely on other things. Again, we rely on platelet counts, rely on kind of the general gestalt, which is really hard to put in an algorithm, to be honest. And there's data for all of these therapies in all situations. So when a patient says, well, what JAK inhibitor should I use? It's really a kind of multi-layered discussion. And with any given individual, I'll often start with simply the blood counts. That's pretty black and white data. We've understood for a given individual, we want to start something to treat their disease. They have a significant symptom burden, they have significant splenomegaly that needs to be addressed, but we often start first with the blood counts. And well, are they intact or not? Because then that helps us kind of sort out at least a little bit which kind of JAK inhibitor we might want to go for. And really add that in with the splenomegaly and symptom burden that a patient might be dealing with, but then think about the whole picture. Transplant timing, I think, is one thing, right? So if you have a patient who's looking to get to transplant, there's a wealth of data now suggesting that JAK inhibitor prior to transplant improves post-transplant outcomes. We want to think about access. Access is a big, important thing. Dr. Ritchie mentioned in the Q&A about copays, right? And insurance coverage. That's a big deal. I recall not too long ago, I had a patient, for whatever reason, their insurance, I prescribed ruxolitinib, their insurance would not cover the ruxolitinib, and they had a huge copay. And then I turned to fedratinib, and just the way the patient's assistance programs line up, that patient had no out-of-pocket costs. So I actually did frontline fedratinib for a patient because of access issues. So that is a big, important part about things. Concomitant medications, there's lots of interactions. So pacritinib can prolong QTC. So if a patient has another medication or a couple of medications that prolong QTC, I would avoid pacritinib in that individual. Comorbidities, right? So if a patient has bad neuropathy, I might avoid momelotinib for that individual. And then, patient preference, I think, is an important factor in deciding treatment as well. You kind of lay out the options, you talk about the risks and benefits for each, and make that shared decision. But at the end of the day, I think the important thing is listening to your patients and understanding where they're coming from, what are their goals for treatment, what are the things that are most bothersome to them, and kind of arriving at a mutual decision. right? We're taking care of patients. We don't take care of spleens. We don't take care of, well, we take care of patients who have fevers, but we don't take care of fevers, right? We take care of a patient, and it's a group effort between the patient, the doctor, the nurses, the patient's caregivers, family members, all really to get there. And a lot of us advocate for this shared decision-making model. And there's lots of papers that have been published on shared decision-making models where giving guidance to caregivers on how to get there, right? This is one of the ones I pulled. It's called the SHARE model, where you seek a patient's participation, you help them explore and compare treatment options, you assess their values and preferences, reach a decision with the patient, and evaluate the decision going forward. It's a nice little tool to remember. I know a lot of docs will just do this intuitively, but I think it's important. In a busy clinic day, your doc might be seeing 40 patients, and it takes a lot of time to go through this and really have these kind of meaningful conversations. I understand it's difficult, but I think as a patient, the doc and the caregivers that you have owe it to you to kind of go through this process so you're all on the same page. Of course, there's a lot of unmet needs. We're trying to address those. You heard about a lot of exciting new therapies today. We keep moving forward, and really because we've come a long way with the treatment in 2025, but we're not there. And I know it wouldn't be a good talk if I didn't mention disease modification. So we really need diseases that put transplanters out of business, or treatments that put transplanters out of business, not disease. Sorry, we really need treatments that put transplanters out of business. We need treatments for thrombocytopenia. Last year, I was asked to give a talk on the treatment of thrombocytopenia in myelofibrosis. It was a blank presentation. There aren't any drugs that specifically improve platelet counts in myelofibrosis consistently outside of, again, a transplant. And then treatments for anemia. There are a handful of good treatments that are commercially available, but they're not perfect. I mean, if you ballpark kind of guesstimate how effective these treatments are for treating anemia in myelofibrosis, they're all about 25 to 30%, right? Danazol, ESAs, luspatercept, these available therapies, even the new JAK inhibitors that improve anemia, roughly a third of the patients will have significant improvement in their hemoglobin or benefit there. And that's not perfection, right? We want to be better than that. 30% of the time it works every time is not good enough, and we want to keep moving these things forward. So with that, I think we do have kind of a mix of optimism and pessimism here that breeds a healthy look forward that we can, in fact, do better.